Great. I'd like to, if I could, take a moment here to welcome everyone to our symposium, Think Bigger, Leading the Research Revolution. As you'll see, we have an excellent round of speakers. I'll begin shortly, but let me just briefly give you a lay of the land as we'll be moving forward. So I'll speak a little bit broadly about leading the research revolution, why we need large collaborative studies. We'll be having a number of individuals who themselves don't need an introduction. I suspect they'll introduce themselves when they put their talks on, but we'll have Dr. Xavier Griffin, who will be speaking about the power, in this particular case, the power of randomized trials, or more importantly, why they still matter. I'd like, if I could, to invite Professor Griffin, Xavier Griffin, to speak a little bit about randomized trials and why they matter. Dr. Griffin. Oh, I'll just have you off mute there.
Very good, very good, good spot. Thanks, Professor Bandari. I was just saying that I was thrilled to be here on such a worldwide group, and I'm joining you now from East London at Barts. And I'm going to speak a little bit about randomized controlled trials, which is one of the designs that Professor Bandari was talking about. Why am I talking about randomized controlled trials? Well, because I really believe they matter, and they matter a lot. Now, really, when it comes down to it, as a clinician, why do they matter to us? Why should we care? Well, I suggest to you that you could perhaps rephrase that question and consider, why do I need to read a randomized controlled trial? Why do I need to pay attention? The answer could be expressed as, should this change my practice? Does the work that I'm reading influence how I'm going to treat my patients? And today I want to try and convince you that the randomized controlled trial is the single best study to influence how you decide to treat your patients. Now, you're going to hear many, many things said over the course of your career where people tell you, yes, you must read randomized controlled trials. Great advocates of the randomized controlled trial, and they're certainly expanding with the work that many of the people on the panel here today have been involved in. But then again, you'll see a lot coming out of increasingly the health technology appraisal organizations such as the FDA, suggesting that they're very slow, that we can't keep pace, and that big data might be a more valuable tool in the pursuit of answers. And then possibly the real answer is maybe, and we'll come on to discuss that. And I'm going to try and take you through some of the thinking, some of the journey that I've been on to understand why that's the case. The first thing, I love getting down to the background, to the sort of meat behind these questions. And you really have to delve into epistemology of what you believe about truth. And I guess I should say right up front that I'm a trialist, but also I believe in the concept of a single universal truth to an answer that underlies our inquiry. And the purpose of conducting our experiments, whether they be big data, epidemiology, randomized controlled trials, is to try and reveal that truth. That's important because it underpins the entire concept of the work that we're doing. Now, it's not just me that believes that. Actually, there's a long track record in this type of work. And I want to introduce you to two people that I would say you should go and do some reading about if you're really interested in study designs. So this is Sir Ronald Fisher, early 20th century statistician, geneticist, and really the grandfather of randomized experimentation, probably the person upon which we hang the underlying principles of randomized studies. To understand him in the round, though, you should be aware that he was a member of the Eugenics Society at Cambridge, so somewhat potted history. Shortly after him, Austin Bradford Hill in the 1940s developed what is probably recognized to be the first major randomized controlled trial in medicine, and that's the 1940s MRC streptomycin trial against TB, the first biomedical trial. And Bradford Hill is probably the other great bastion of information about how we now design our trials. So get onto Wikipedia, get onto something easy to access, and read a little bit about their work. So look, big data has had a really strong part of our work over the last 2 years with the COVID pandemic. You know, worldwide crisis, colossal proportions, massive public health, economic, and civil liberty concerns about the impact of COVID and the treatments and/or public health interventions that are being rolled out. We really, really, really needed and wanted to know what the actual truth was. Well, there's a nice systematic review just been published recently where they looked to see how much big epidemiological work had been done prior to the first definitive randomized controlled trial. That was recovery, and there were 43 studies. Now, those 43 studies generated what was relatively uncertain, but enough for the FDA to approve hydroxychloroquine as a drug for the treatment of COVID in hospitalized patients. And we're going to come and talk on a little bit about that later. But the interesting thing is the first large-scale randomized controlled trial of the scale that Professor Bandari has been talking about showed no benefit of hydroxychloroquine. And that really speaks to the issues that we have going forwards about how we might concern ourselves with reading this information. Now, look, there's a huge amount of literature out there where two sides are arguing with each other. And there's this great publication here from a friend of mine in Oxford, Martin Landry and his colleagues in the Big Data Institute, really espousing what they believe to be the benefits of randomized controlled trials. But I would put it to you that whenever you read strong advocates' work, you end up with a pretty dichotomous argument. Some of the nuances are lost, and it's very difficult as a third party to weave your way through to understand. So hydroxychloroquine, we touched on it previously. Hydroxychloroquine was being rolled out by the FDA all across the world. People were using it, and they weren't randomizing patients. What they were doing was treating them with hydroxychloroquine. But what the team in Oxford managed to do alongside the whole of the NHS was to randomize patients to the use of hydroxychloroquine. Now, you can say, well, possibly those patients should have been treated with the drug if we believed it to be effective. And of course, that's true. But the crux of it is we believed it to be effective based upon the epidemiological work. And in fact, there was some examples of potentially research fraud, and Lancet retracted a publication of 100,000 patients from the Surgisphere Corporation. But also there was a lot of uncertainty into whether the epidemiological studies that were not fraudulent were actually telling us the truth. And when you dig into it, if you look at the Recovery First publication, there's really very tight confidence intervals and no effect. So hydroxychloroquine, we've got a nice case example of a randomized trial coming in behind epidemiological work to demonstrate that it was wrong. Here's another good example. So statins, we know statins work really well if you have severe cardiovascular disease. The contention in the literature is where you should use it in primary prevention. So these are low-risk groups who haven't had ischemic heart disease events. Should they have statins? Now, what's the big deal? It's just a cheap drug, doesn't cause any problems. But is that true? And certainly if you look at the big data coming out of Europe, there's a lot of evidence from that people that are treated with statins have an association with potentially a higher cancer risk and very commonly myopathies. And that has led to an overall decrease in the amount of statin that's being prescribed, certainly in Europe. Now, if you look at the randomized controlled trials, and there's a lot of randomized controlled trials now, when you synthesize them in a meta-analysis, what we see is actually that quite possibly we are doing our patients harm by not exposing them to the statin. And here is a nice slide from a meta-analysis, albeit from the trialists that have conducted many of these trials. And what you can see here is the line of no effect in the center, and the purple dots with their confidence intervals illustrate the potential complications. So myopathy at the top there, muscle symptoms and muscle disorders, and not much evidence in the trials that there's any difference. When you look down at the red dots with their confidence intervals, you'll see that the big events that we're trying to prevent in primary prevention, myocardial infarction, stroke, and death, hugely beneficial to take a statin. And so here we really are seeing the conflict between evidence that we're generating from randomized controlled trials and the evidence that's coming out of epidemiological studies. So what does this mean? Well, I'm going to take you back to some of that basic concept that we talked about our pursuit of the truth and inquiry. So let's imagine for a moment that we have a target, and the yellow center of the target represents the truth. And we're going to do an experiment, and that's represented by an arrow flying down the range, and we want the experiment to give us the truthful answer. So that would be dead center in the middle of the target. So what types of different experiments might we do? Well, here's one. Here's a series of experiments. Five arrows have been sent down towards a target, and they've all landed pretty closely together. So they're giving us the same message, and that message is therefore quite precise because we're giving the same information. But you can see that systematically, there's a difference in the answer from the truth, the center of the target. And that systematic error is what we call bias. Now, there can be many reasons for bias, but a study or design that yields precise but systematically incorrect, biased results is a design that can potentially lead us down the wrong path. And this is the great concern with epidemiological studies. So typically big data where we have an awful lot of patients is often precise, the confidence intervals are very tight, but because of the fundamental lack of randomization, it can lead to a biased result. Now you've got to remember that in reality, we never observe the target, we never see the truth of the target, all we see is where the arrows land. And so all of our information is just from the arrows. So what happens in a trial? Is a trial a perfect way of answering the question? Well, yes and no, and that's the nuance to this discussion. So a trial might yield results like this if we repeated the trial 5 or 6 times. So here, you'll see that if we averaged up all of the effects, we'd see that the overall average between all of those arrows is pretty much in the middle. Therefore, it is unbiased. There's no systematic difference between our experiments and the truth. But any one observation, if you just took one of those in isolation, you might be lucky. You might get the one that's right in the middle of the yellow target, and you'd get the answer perfectly right. But you might be unlucky, and you might get one of the ones in the gray circles, and so you'd be off. But you wouldn't be biased, you would be imprecise. And that's the important distinction. So the great power of randomization is it allows us to quantify the degree of imprecision in a way that no other study design does. And in fact, if you take a very purist view of Fisher's experimentation work, you could make the argument that unless a study is randomized, none of the statistical tests that we use make sense. So let's just revisit that in a slightly different way, because this is a really fundamental component to why randomized controlled trials are important. Many of the things that you hear about trials are true to an extent, but are not the real reason we're doing it. Here's the reason. So we want to know the truth. Now, what is the truth? The truth is some combination of what we observe in our experiment combined with a degree of error. We want to understand, we know what the observation is because we observe it. What we need to quantify is what the error might be. Now, I've already said that if you randomize, you end up with a confidence interval, and we're able to express our degree of imprecision or play of chance. So the chance component of the error, we can quantify if we randomize. The bias component is not quantifiable. There's no statistical way to enable us to quantify what the bias is. The only way to establish what the bias is to randomize. And in a perfectly conducted randomized controlled trial, that design built in at the front end of randomization allows us to say that the bias is 0. And now we end up with the equation, truth is our observation plus the play of chance, which can be quantified in a randomized design. So I'm going to put it to you, and perhaps we'll discuss later on, that randomization is really the only way that we can answer questions about effectiveness. But we know that there's many different ways of answering the questions, and I do stand by this. Although I believe heavily in the randomized controlled trial, I don't believe that a dichotomous argument about the role of different types of study design is very helpful in moving us forwards. And actually, the primacy should be about our intellectual rigor and about our desire to pursue really great research. So I'm going to hand over back to Professor Bandari, and we're going to talk a little bit further in this symposium.
Wonderful. Thank you very much, Professor Griffin, and a very clear presentation. So we've had a few questions come in, but let me, if I could, begin with a question that was brought up by one of the listeners this afternoon, this morning for some of us. This was Dr. Pullman who asked a question to us, and I think, Xavier, I might raise it with you first, but get other panelists. He asked the question is, if small studies are so, quote, problematic, should we really now be promoting larger collaborative studies, which seems logical, but should we make a real strong move against even the conduct of small studies? Is this even a proposal that you'd entertain? Or maybe I might flip it to you and say, is there value in small studies?
Yeah, so I think that's a really fantastic question. So I think the end point is that we all want to be doing really large collaborative studies for all the reasons that Professor Bandari has spoken about. I'd say to you that a small randomized study, that's one of those arrows landing in my target. And it in itself might have the play of chance, and it might land away from that yellow central target point. But it's still, if it's a well-conducted small study, is unbiased. And so it still adds in a meaningful way to the evidence base. And aggregating together small studies through meta-analysis allows us to try and refine the precision, so reduce down that play of chance. Then one wonders whether a meta-analysis which aggregates lots of small studies is superior to one large randomized controlled trial, and that's kind of open for debate. I don't personally like the sort of very hierarchical description of levels of evidence. I find it to be a little bit constraining because, of course, it depends upon the quality of the evidence that we're putting together. So we could do a very large international collaborative study which has got some biases creeping into it. Equally, we could do a meta-analysis of really fabulous unbiased small trials, which might be more helpful. So I think you have to judge each individual on the case there. So I wouldn't dissuade people from doing small trials, and I have done small trials, and I've done them in order to refine techniques in order to do bigger ones. I think it adds to the evidence base. But what I'd say is if you are going to do a comparative study, you must randomize it.
Xavier, do you have any other comments related to research fellowships?
Yeah, I mean, I'm fully supportive of what you suggest, Mohit. I have experience of one Dr. Adi, who came from Ian Harris's group in Australia, and he visited us in Oxford for a period of I think it was 6 months, perhaps even a year. He came as a clinical fellow. He's an orthopaedic surgeon, but his explicit reason for coming was because he wanted to be exposed to the research environment and how we were doing business. And as you know, I've just moved down to Barts, and one of the things that we're setting up is a research fellowship. So anyone that's interested, get in touch with me.
Excellent.
They're hugely beneficial.
And maybe just as maybe one of the closing thought from you, Xavier, on that same issue, how do we attract more people? I know you are invested as a surgeon scientist. How do you attract more people into this, very small path that's taken, but it's a critical path we need?
Yeah, I mean, it's tough. It's tough to balance and create space in a surgical career, which is already pretty demanding. So I make no bones about the fact that it's, no pun intended, that it's a difficult choice. So I'm honest and upfront with people, but what I say is that, we need to lead research for the benefit of our patients, because if we're not doing the research, somebody else will be doing it, or worse still, no one will be doing it, and there will be consequences for our patients. And so I say to people, actually, my most profound impact will not be on the patients that I operate on. And any one of us, even in the very largest centers, will have relatively limited impact in terms of the individual patients that we treat. And of course, there's value in that. But those of us who choose to try and create the sort of research culture that allows our trainees to move forwards and become research active surgeons, surgeon scientists, could potentially have a colossal impact on how the practice of orthopedics is taken forwards. So I lay it out there as an offer for people that want to run with it and grab it, and then try and facilitate as much as possible those people that choose to take up the mantle to make their path possible.
I can't thank you enough. And I think on that note, I'd like to take a moment to thank all of our speakers this morning, this afternoon, I'll say, depending on where you are in the world, for joining us for an exceptional session. And let me remind you again that it is time for a research revolt. So let me remind you again that it starts with you. Evidence is going to be your storytelling tool, whether it's small or large, randomized trial or an observation or a case study, whatever it is, get going. Simple ideas. Focus on simple ideas, friends. Our world is much smaller than you think, and keep learning. SICOT has lots of tools, but there's lots of people and mentors around that you can access. And the last part, the T, is today. Why not? Why even bother waiting for tomorrow? Start today. Thank you all, my friends. Thank you all to our faculty, and wishing you all a continued excellent hybrid session at SICOT. Thanks again.